Greetings once again. It's a pleasure to be back. And for this particular session, I'm going to talk about why NHIF, the National Hospital Insurance Fund, has to rethink its operating model to deliver on universal healthcare coverage. We all know as a country and as a global community, there is a focus on ensuring universal healthcare coverage, access to quality healthcare services by every individual, every patient, wherever they are, whenever they are, without suffering any financial hardship or constraints, and without not actually, if the healthcare services need to be accessible to where they are, accessibility, availability, and they need to be affordable. So on those three particular areas, when we look at it from a Kenyan context, the focus has been on having NHIF as the vehicle towards the realization of universal healthcare coverage. And if you remember well, in 2017, when President Uhuru Kenyatta was re-elected and got into office, he rolled out the Big Four agenda. Another Big Four agenda, universal healthcare coverage was one of the biggest pillars, and he's been working on it. And with that, the pilot scale was on having NHIF actually the driving vehicle and rollout of UHC in 4 different counties across the country. And with that, we see that focus on NHIF being the vehicle. And what do we mean when we talk about NHIF being the vehicle towards the realization of universal healthcare coverage? Oftentimes, we know as a country, because of our financial and economic status, we are not able to afford healthcare services when and where we need them oftentimes. And on that account, then it would be viable for us to have an insurance cover that is a social public insurance cover that could ensure that whenever I'm unwell, I can get healthcare services in a hospital or in a healthcare outlet near me without having to suffer the cost. And oftentimes we know most of us have been in different WhatsApp groups where you are being urged to contribute to some finances, help someone pay their hospital bills and all that. These are not experiences that we would wish for, but they are the reality. The question is, how do we overcome them? And to overcome them, then we need an insurance scheme that can be able to address such shortfalls. It's not only for those who are having substantially higher bills that we are called in to contribute to, but even the very minor costs of healthcare. When, for example, you go to see a patient comes to the pharmacy to the hospital, and after getting consultations and all that, they're being told to go buy medicine. Because of their financial capability, they are not able to buy medicines. Some will buy half dose, some will not buy at all. And then what are we doing as healthcare service providers? This is the shortcoming in our society, and these are the things that we need to look at. And when you talk about it from NHIF perspective, I know there have been reforms with the appointment of the new CEO that started last year, but 2019, 2020 years. And from 2020, with the new CEO in place, 2021, we've been going through these reforms. National Hospital Insurance Fund, now it's the Health Insurance Fund, which is a good thing for us because it now goes beyond the hospital care, going to even look at the whole spectrum from preventive, promotive, curative, rehabilitative, and palliative healthcare services. But at the same time, we need to acknowledge that NHIF, as it is working, is not delivering on that mission. And that is why when we talk about it, oftentimes, less than 30% of our Kenyan population are covered by NHIF. And that is quite a bigger number that we need to be thinking of, because if you look at the ways insurance schemes work, that is not sustainable. And it's not going to give us the results that we hope for. And when we talk about the scope of services, we know we have outpatient and inpatient services. Outpatient services are normally reimbursed through the capitation model, where as David, I would choose a particular health facility that would be my outpatient facility of choice. And on that account, then it means over time, whenever I'm unwell, I'm able to go to that hospital. Unfortunately, based on the amount that is reimbursed, the scope of service that I'm able to get in that particular facility when I go for outpatient services might not be commensurate to my contribution or might not be sufficient in terms of what my needs are. Let's say I go to a hospital, I'm being told that outpatient cover can only cater for consultation services, and therefore I'll have to buy medicine, pay for lab works, and any other services. Then the question is this insurance serving me, or is it a way to get money out of me? And those are the things that we need to look at. For the inpatient services, there's a margin of how much you can spend and how much you cannot, beyond which you now go to the co-payment models of service delivery, where it means as a patient, the NHIF will cover what it has to cover, but beyond that, I'll have to pay again. So how limiting is that, especially when I need services that I might not be able to pay for? That is where we have people contributing in terms of WhatsApp groups, Harambes, Mchangos, and all that. These are things that are happening in our society. And the panel of enlisted service providers as well. When you talk about the panel of enlisted service providers, for you to be able to offer healthcare services to patients, who are under NHIF cover, you have to be an enlisted service provider. You have to be empaneled onto the NHIF list. And on that account, then who are the enlisted service providers? Oftentimes, actually, so far, mostly we have hospitals and clinics. We don't have any other healthcare service outlets. For example, we talk of pharmacies. Yet we know that some of these other non-enlisted service providers are playing a critical role. Nursing homes and related, some which are not, are still offering critical healthcare services that need to be financed in a part one way or the other. So how do we make it be financed? Then we also need to understand, actually, in this particular phase, as NHIF is talking about rethinking its operating model, reforms and all that, we need to start from the basic principle in terms of healthcare service delivery, which is one, ensuring patients have access to the quality healthcare services and products that they need when and where they need them at the lowest possible price or the most affordable way they can. And if they're not able to pay for it from their pockets, it has to be paid by somebody. And this is where the insurance comes in. And this made me actually reflect on a quote that was said by Jeff Bezos, founder of Amazon. When he was asked about what he would see as the trends in the next 10 to 20 years or so, he noted that he might not be able to do that. And definitely we are not able to predict the future with utmost certainty. But as much as we can predict the future, one thing that we know is the constant that will always be there. There's never a customer who wants to pay the maximum price for anything. And therefore we know that customers want quality products and services at the lowest price possible and in the most convenient means available. Therefore, it means in that case, when I look at it from the healthcare service spectrum, I want to get quality healthcare services. I want quality medicines and quality medical products and healthcare products, but I need to pay the lowest price possible for them. And in the most convenient way in the means, I don't have to queue for an entire day to get paracetamol in a hospital, then be told to buy other medicines. That is one bit. I don't need to waste for, let's say, for example, 2 days to have my consult appointment be there booked. And I need to be able to get medicines with refills after a period of time without having to delay so much because I can use digital technologies that are coming up. So are we going to ensure the convenience of this advancement in terms of technology and digital platforms and making healthcare services available? And when I need them, I don't have to pay so much money because I need them at that time. And that is why I believe NHIF has the answer. And NHIF has the answer, just that it has to rethink its decision-making, its operating model, and ask itself, are we going to serve the Kenyan people, or are we doing it on a business metrics that does not realize what we are hoping for? There have been conversations in the space about that, which are ongoing, and I'm hoping the different stakeholders that are playing their role are going to shape this conversation towards the NHIF we want. And in my perspective, these are the kind of recommendations that I would have for NHIF in terms of rethinking its operating model. One, NHIF and the steering team has to understand the consumer decision journey. If this is delivery of healthcare services, you need to ask yourselves, who are the consumers of our services? Who are the people who are getting insured? And on that account, then we need to say, the consumer is the patient and the patient's beneficiaries, or let's say, for example, if it's me, I know I have my parents. If they're my beneficiaries or so, or if my mom was the person paying for NHIF, then the question is, how does that influence my healthcare consumption patterns? So on that matrix, if we look at it, then if I'm unwell, where do I go to? And if where I go to seek healthcare services is not part of the enlisted service providers, then I don't have an incentive to pay for my insurance cover. So am I going to pay if I'm, let's say, for example, oftentimes when I'm unwell, I'll go to the pharmacy to buy medication that I feel are good for me, or I'll go get consultation over-the-counter medicines, whichever way, I'm still dealing with a pharmacy. But a pharmacy is not an enlisted service provider in the NHIF panel of service providers. And therefore means I don't have a reason to pay insurance, NHIF insurance, because oftentimes I don't think I'll have a need for it. They don't need to go to a hospital. So that is where we need to look at what is the consumer decision journey. And oftentimes this is across Africa continent generally when you look at it. The consumer decision journey models, patients going to pharmacies, one, when they have symptoms. When the symptoms persist, they go back to the pharmacy again. Then from the pharmacy, they can go either be advised to go to the hospital or they'll be given medicine still. And if those who go to the hospital, ultimately they'll go back to pharmacies. And we know our public health systems are kind of failing in certain areas where they don't have the medicine. So it means at the end of the day, even if the capitation has worked for me to get consultation, I'll have to go buy medicines again in a pharmacy. So is it serving me or not? Oftentimes it's not. And that is where there's a detachment from what NHIF is doing and what the consumers need. And that is where we need to see who are our consumers and how do we do it. And that is where I'm thinking once we understand the consumer decision journey, we have to broaden the scope of services. NHIF should cover more services than what it does now. It should be able to cater for actually even medicines for patients who need medicine. Because when I'm unwell, the consultation has a role, yes, but ultimately what gets me well is the medicine that I'm going to take. So if I'm getting consultation services and failing to get the medicines which will cure me and actually eradicate the infection in my body, then it's of no value. And that is where we need to ask ourselves, are we delivering what people need? And this should be based on the public health needs of individuals and based on even the geographical regions, which are the high-risk areas for particular diseases. Can we have a robust, comprehensive cover that looks at such kind of needs in that community? And how do we make it work? Then these other aspects as we do that and actually open up to have more service providers, more services that are being available to be offered through NHIF, we are broadening up our membership base. And looking at the business model for insurance schemes, that is the surest way to ensure we have sufficient finances to help NHIF meet its obligation. That is, we'll have more people signing up, more people paying their membership subscriptions, but then as much as they're paying, not all of them will be using the services. And if they're not using the services, meaning the money is available as kind of a reserve bank, we're able to competitively deliver quality services and ensure those who need them get the quality they need without having to incur extra costs in terms of the financing. It might come with maybe adjustment in terms of the scope of the cost of that insurance scheme, but as much as the cost is higher and people are getting value, it is of more benefit rather than having a lower cost, but people are not paying because they don't have a need for it in terms of what benefit they'll get out of it. And those are things that we need to look at. Then we now need to restructure the financing models. That is where I'm talking about capitation and reimbursement. NHIF, when you're unwell, let's say, for example, outpatient services, there's capitation. My outpatient facility will always be getting a standard amount of money for my care. Whether I'm sick or not, they'll still receive the money. And then the reimbursement is for this majorly inpatient or major procedures where NHIF will pay for a particular set of services. And that is currently what is working. But the question is, when you need, let's say, for example, you need a particular service, do you get, let's say, for example, all the other insurance schemes that we have? You have a car insurance. Does your insurance pay a certain amount every day for your service, car service? Definitely not, because they pay for the need when it arises. And that is where capitation is failing at in separate ways, because it's kind of supporting the institutions, yes, but when I'm unwell, because they are supporting the institution to be able to offer services for me, I'm not able to get the services. So I have no reason to follow up on that. And I think that is where now NHIF could look at the financing models to be reimbursement, and the reimbursement is linking me to the next point where I'm talking about adoption of digital technologies and solutions to ensure that if it is me, David, unwell, if I go to a hospital, biometric systems are actually integrated now. It means I will self-identify as David at that institution. Whether it's my outpatient service provider or not, it's already identifying me as the person seeking the service. I'll seek the service, the amount that is needed to be catered for will be paid, and the NHIF can actually have a cap on how much I can use within a year based on my healthcare needs, when for outpatient and what I can use for inpatient. That still works, but it works only if we have a common framework. And the challenge that I'm having with this capitation model is, let's say, for example, I'm in Western Kenya. That is where I've based most of my time. I fall ill when I'm in Nairobi, where I'm in, let's say, in the coastal region, doing for business purposes or even work-related activity that I'm taking me there for a week or so. If I fall unwell in Mombasa and I need outpatient services, does it mean I have to travel from Mombasa back to Western to get the care that I need? Doesn't make sense. Yet we have technology that we can have real-time data transfer in know where did I fall ill, where does the money need to be paid when I'm unwell. It therefore means every hospital will be competing to offer competitively better services to get patients that they serve. That is one, hospitals and even the pharmacies and whatever, the service providers. And if that is happening, people use them, and the payment is based on where did they get the service. And it will also have the grading system where we have the public reviewing the services they receive in the hospital. Therefore, NHIF can actually have control measures to ensure that the services they're paying for are quality services, not just basic services that are not meeting the needs of the patients. and that is about rethinking our operating model. Are we going to incentivize people to be onboarded based on the value proposition? What is the return on investment? We look at that, then that is done. Get the services in place based on what the consumers want, when they want them, where they need them. Then integrate technology. We can't be talking about technologies, yet we are still doing things manually. And that is where we need to look at it in terms of health information management system, the digital technologies in terms of relay of information. Where do I get services? Do I get identified at that facility? How much should be compensated? So that we have a model that delivers on what we need to get. And let's get people to invest in healthcare systems. Let's get people to deliver on their healthcare promise. And I believe with that, we'll be in a better position with NHIF actually being the vehicle towards universal healthcare coverage, because patients have a need and they see value, they pay, and they be the members of NHIF. Healthcare providers deliver quality services because that will determine whether they are getting people onboarded into their panels or not. Therefore, there's a competitive angle to it. They improve their quality. That is what we want in terms of quality. Ultimately, NHIF with more members, quality services, and financing it based on what needs to be done, we are a winning country. That is what we need to think of. And I hope that is going to get us to the next level. And most importantly, I think as pharmacists, we need to position ourselves as healthcare service providers and be critical players, because if patients keep coming to you and they have to buy medicine from out of pocket, then if you would be enlisted as a service provider, that would be an additional value, because you are a healthcare service provider running a healthcare facility, offering quality healthcare services, and broadening the scope from products to pharmaceutical services, which could also be part of the services within scope. On that account, we'll serve our patients better. And I hope that helps us transform our practice. Thank you so much. If you enjoy this, please subscribe, like, and share with your colleagues. Let's shape the future of our healthcare systems. Let's deliver on healthcare for our patients. Thank you.